Well, hello. Welcome back to another Miles for Hips interview. We are very fortunate today to have Julie Jacobsen joining us. Julie is an associate professor at the School of Health Professions at VIA University College in Denmark. So, Julia, thank you so much for joining. I know this was a little challenging for us to coordinate, especially with time zone differences, but so fun to get to meet you and have you join us today. And I thought we'd start just very generally. Tell us a little bit about your background and specifically how you became interested in hip dysplasia.
I'm a physio and I've been working as a physical therapist for many years. And I think some first years where I was working and treating patients, I actually treated a lot of patients with hip dysplasia. My primary work was to rehabilitate patients undergoing PAO, so peri-acetabular osteotomy. And as part of when I treated these patients, I became very aware that most research within hip dysplasia were very focused on bones, cartilage, and blood during surgery, and scar tissue. And there was less knowledge about how do patients actually perform before and after, what about their muscle strength, their ability to participate in different activities, also using a questionnaire that was actually designed for younger people and not only questionnaires designed for older patients with hip osteoarthritis. So very early I became aware that a lot of the knowledge that were actually used within hip dysplasia were actually not fit within this patient population. So both the outcomes and the patient-reported outcomes we used were maybe designed for other populations. And then also the part that I think you can call it a bit physio-related outcomes. So how the body actually functions, both before and after surgery. There's very little knowledge about that. And therefore, I started to do research within hip dysplasia to try to improve both our knowledge, but also then the treatment of the patients.
Well, that's wonderful. And we definitely need people like you involved in hip dysplasia care for sure. I know you and I talked a little bit offline before jumping on here, and so excited to have you share about some of the projects you're involved with. But can you discuss some of the either current or previous hip dysplasia related work that you're currently working on that maybe excites you?
Yeah, I can do that. I think I can both talk about some of my previous work. I did a PhD within hip dysplasia also, and the primary focus of my PhD was to investigate extra-articular affection, so muscle and tendon affection when you have hip dysplasia. And that was because I noticed as a physical therapist that there was a lot of patients, both before but also after surgery, who also had a lot of injuries to their muscle tendon tissue, but it was not really either investigated or maybe acknowledged that that was a huge problem for many patients. So I started to make a lot of research and then identified that a lot of patients actually had injuries in their muscle and tendons, both before but also after surgery. And that was a focus that we need to also manage when we are both treating patient but also rehabilitation patient after surgery, that we have to also take care of their muscle tendon injuries at the same time that we also take care of that joint. Yeah, so that I think that was quite important work also.
I think that is hugely important, and I think that's something that is very not well understood, and is probably a very important part of rehab. I know a number of adolescent adult patients who undergo PAO surgery, and the doctors are going, "The bones look great. You should feel
Yeah,
fine." And a lot of people still struggle with muscle and tendon pain
yeah,
operatively. And I think we forget that before surgery, this is not a normal structure. So muscles and tendons are having to work kind of an overload to stabilize the joint. Then you have
exactly.
surgery, you change your anatomy, and you kind of expect everything else to just fall into place. And sometimes
Yeah,
it's not so easy.
that's right. And we actually saw that a lot of the patients, and this also makes good sense if you think about what hip dysplasia actually is, that it is a reduced coverage of the femoral head. So we saw that a lot of the patients had injuries to their muscle and tendons in the anterior side of the joint, so in the hip flexors, but also in the lateral side of the joint, they also had a lot of injuries. And that's both places are places where the muscles have to work to create stability from this a bit unstable joint. So it makes good sense, and what is good for the patients, and I think also for us as professionals, that when you have muscle tendon injuries in your hip flexors or lateral hip abductors, it's actually possible to treat these injuries with exercise. So it's something that's also manageable, that you can actually manage also before surgery. So if you don't have any joint injuries, it's also possible to help the patients before the joint actually get an injury.
I think that is such an interesting concept and something that really is not valued in hip dysplasia care. I think a lot of patients present with hip dysplasia and the option is surgery. They go, well, you don't have coverage. We clearly have to give you coverage. But like you said, stability comes from a lot of different areas around the joint, including, the bone stability is important, but it's one layer. And it sounds like your team has explored a bit going, okay, there are multiple layers, and some of these we actually can treat with physical therapy. It's not going to take away the fact that there's decreased bone coverage, but if the issue is pain and decreased function, looking at can we treat other things around the joint, either in preparation for surgery or as an alternative, whether temporarily or permanently.
Yeah, exactly. Yeah.
That's
the idea. Yeah. So that's one thing. And that's, of course, some of my previous work. And now I'm running a trial a randomized controlled trial where we are comparing two treatments for patients with hip dysplasia. And one treatment is an exercise and patient education intervention where we both apply specific exercises, but also patient education. So what do I have to trying to learn the patients, what is hip dysplasia? What do I have to be aware of in my spare time? What kind of activities can build up my joint? And there may also be activities that may be better if they don't do too much. So we try to build it up with, I would say, a huge, what can you tell? A lot of different information about what hip dysplasia actually is and what do we recommend and do not recommend for different activities.
And just I was just going to say for the audience, for people who might not be as familiar with the study designs, research designs. So an RCT, a randomized control trial, which you're talking about, for people unfamiliar with this is a very high level quality of research. There's all different kinds of research, but a randomized controlled trial, really you have patients who are being put into one, different treatment groups. So for this specific one, the one you're talking about, it's education and exercise compared to.
Then we compare to usual care.
Okay.
And usual care is also education. So you can say it is exercise and patient education compared to only education.
So looking at that variable that we're trying to see if it makes a difference is that exercise program.
Yeah, exactly. Yeah. And then what I think is also maybe a bit special is that the patients we include in our trial is only patients who are not candidates for hip preserving surgery. So we're interested in helping the patients who are told they can't have the surgery, maybe because they have too high BMI. Some of them are older than 40 years and then they won't make the surgery in Denmark. We will also have some patients who have already developed hip osteoarthritis and then they also do not make this kind of surgery on younger patients. And then we are trying to make an alternative for these patients, trying to give them an option either of exercises or patient education or this combination. We don't have the results yet, but we are recruiting and we are aiming for 200 patients and we have recruited 125 now. So
that's amazing.
yeah, I really hope that we are able to finalize our recruitment within 1 or 2 years, and then hopefully in a few years we will be able to distribute our findings. So it will also be helpful for both patients and professionals, this kind of study.
This is going to be amazing work. And like you said, so your study, just to summarize, really is
Mm-hmm.
intended to look at people who are not candidates for PAO. So,
Yeah,
or for, yeah, for hip preservation surgery. So these are
yeah,
patients who either have high body mass, so
yeah,
obesity, overweight. These are
yeah,
people who are maybe too young for a total hip replacement but have too much arthritis to qualify
mm,
for a PAO, or
yeah,
who are, yeah, and or people who are too old for a PAO. And I think,
exactly.
you and I were talking, this is a challenging patient population. I see people all the time who are coming on and saying, I feel stuck. And what am I supposed to do during this time? I'm being told I'm too old, or I'm not a good candidate for this surgery, but I'm too young, or for other reasons, not a good candidate for this surgery. So your
Yeah,
study is looking to say, how can we help people here? And it sounds
yeah,
like the thought is that, is there a role for an exercise program?
yeah,
And what are the
exactly.
outcomes you're looking at? I'm guessing you're looking at pain and function as the main, to
Yeah,
see if we can
exactly.
improve, reduce pain
Yeah,
and improve function.
yeah. Our primary outcome is pain. So hip-related pain is measured with a questionnaire. It's called Copenhagen Hip and Groin Outcome
Okay.
Score. But we also look at other subscales. So we also look at sport and recreational function, quality of life, and then we measure some physical. We measure some outcomes within performance. So we measure muscle strength, uh, isometric hip muscle strength. We measure performance, so ability to maintain balance while making a task, and also performance with the ability to take a jump on one leg, on your most affected leg. So we both measure, I would say, self-reported outcomes, so how the patients experience their symptoms, but then also some more performance-related outcomes, I would say. Mm-hmm.
That's
Yeah,
wonderful. This is going to be very rich data when it's available, and the results I think are going to be really important to many
mm,
patients,
yeah,
and certainly is trying to help people make decisions about
yeah,
their care
exactly.
out there.
Yeah,
Um, on that, talking about, so that you're looking primarily at people who are not good candidates. We
mm-hmm.
also chatted a little bit about some work that's also being done in Denmark, looking at exercise as almost an alternative to PAO surgery. But I would love to hear just some of your general thoughts on the role for physical therapy, whether it's for as an alternative to hip preservation surgery, as a role for like prehabilitation and then also rehabilitation. Just your experiences as a physio, where do you feel like that role lands?
I would say the role is within all these different areas. So it's both as an alternative. I would say it's also very important as pre-rehabilitation to prepare the patient for a big surgery, that they get really good function before having to undergo a surgery. Who also have some, of course, there is for some complications, and for others, there's also some time to recover following such a large surgery. So it's really important to prehab patients also before, and then of course also rehabilitating patients undergoing hip preserving surgery. Um, we've just done a few studies where we both have interviewed a lot of patients undergoing PAO, so hip preserving surgery, to try to find out what are their experiences, what are their perceptions of just doing this, and what would they dream about if they could dream about anything. And this was a study we did together with La Trobe University, and it's really nice. So we've both interviewed Danish and Australian patients. And then we've also done another study where we've interviewed physical therapists, both from Denmark and also Australia, and also got some information on their experiences from this very heterogeneous population, where we see patients who are very young, patients who are a bit older. We see patients who are like almost elite athletes, and then there's also patients who are more like working and having small children and maybe just struggling with like normal life activities. So it's really like this huge heterogeneity there is within this population. We also try to describe with our data from these both physical therapists and patients. And also trying to explain the differences between the countries. Of course, there's also differences in how our healthcare system is. So it's really interesting, and I would like to talk a bit more about it if you want to hear about this one time. But I think it's also really important to both hear from patients. What do they experience? What do they dream about? What are their goals? And then, of course, also all the experience of all the professionals who are working with this group, trying to learn from each other and trying to share information and experiences and knowledge.
I think you're right, and I love that you all are doing that work because one of the big things we do with Miles for Hips is just really this idea that it's a team, that
Yeah.
the patient's on the team, the physios are on the team, the surgeons on the team, other maybe non-operative treating providers are on the team, nutritionists should be on the team, psychologists should be on the team, and clearly we need people like you who obviously you're a physio background, but also the research, because
Yeah.
it's so important to have all these people working together and coming together. I would love for I think our community might be really interested in some of your experiences as a physiotherapist, and obviously there's so much that we need to learn about this field, but do you, just through your experiences, not necessarily the research, but do you feel like you've seen certain patterns of patients who maybe respond better to physical therapy management versus surgical management?
I think that's really a hard question
Yeah.
because it's so different. And what I have experienced is that I think in a way I see two kind of groups within the population. So I see a lot of these, I would almost call them athletes who are very physically active, and then they may get an injury one day, and then of course they get pain and problems, but they have a high level of functioning. So they also respond quite good on exercises because they are experienced with the exercise and to do exercises. And I think they do quite good, if I should say anything, both for surgery and for exercise, for both. And then there's this other group who's primarily individuals who have maybe not been so physically active in their life. A lot of them have perhaps been struggling. They have felt their instability from very young age, and not all have gotten the right treatment at the right time. So maybe they've been through a lot of different kind of treatment approaches, could also be different kind of physio interventions, but maybe the different treatments that they've got have not helped them that much, and not all actually recognize or have recognized that they have this condition. So there's this group who've been struggling with challenges and may not have had as good experience with being physically active. And when they then try to be physically active and try to do exercise, they get a lot of pain. So they really also need a lot of support. And I think the support this group needs is a bit different from when you are more elite athlete. That's something else. I would say that some of them do really good. Some do really good with very few advices. So it's just about knowing what to do and what's the right thing to do. And of course, there's also other people or other individuals who are maybe have a lot of challenges with exercise. And for some, it can also be a good solution with getting not just hip preserving surgery, but also getting a total hip replacement when they get a bit older. I've also seen that for many patients. Of course, it's not the first solution, it's not the best solution, but for some who's been struggling for really a lot of years, and maybe they are not candidates for surgery because they're overweight or too old, then I would say the total hip replacement can also be a good solution for some.
Yeah. No, it is. I mean, hip dysplasia is such a gamut, and like you and I talked about, where you kind of look at it. I mean, it's a pediatric condition, it's an adolescent condition, it's an adult condition, and there
Yeah,
really can be very different trajectories. It's a
yeah,
very heterogeneous, or very a population with a lot of different kind of people in it, and a lot of different kinds
yeah,
of experiences and backgrounds. And but I think, yeah, obviously I'm biased as a physiotherapist myself, but I do agree there's a very strong role for physical therapy, both from a prehabilitation, before surgery, rehabilitation, um, and then also from a huge point from an education standpoint, activity
yeah,
modification standpoint. But
yeah,
then I'm so excited about the work you're doing, because I think giving an alternative for people who otherwise feel very stuck in the middle of not being a good candidate for surgery, and
yeah.
facing a period of time of just chronic pain and limitations in what they're able to do. So I think I'm very excited to hear the results of your work, and it sounds like, give you a couple of years, and hopefully we'll
We
have it.
hope.
That's a huge endeavor,
Yeah,
though. Our
yeah,
randomized controlled trials are very hard studies to get approved.
yeah.
They can be hard to recruit for,
Yeah,
and you need lots of patients to be able
yeah.
to really say that what we're finding is truly what we're seeing. So anyway, just congratulations on that. That's huge, and we'll be very excited to see it. What opportunities do you see for future hip dysplasia related research or education? What do you feel like are some of the biggest needs or gaps that maybe you'll look to fill next?
I think the first one is actually to create more awareness about hip dysplasia. I see so many young women who are not identified with the disease, and they struggle and have a lot of challenges, and also for some, also mental challenges because they are not acknowledged for their pain. So I think really timely diagnosis, so they know that they have this condition, and then also, of course, when they get a diagnosis, we should also help them either with exercise support and for some surgery if it's relevant, of course. So I would say really timely diagnosis. And for that, it's really important that a lot of different professionals know about hip dysplasia. So it's both the general practitioner who have to be aware of that the young female patient may have hip dysplasia. It's also the physios around, because of course a lot of these patients, they take contact and try to get help from different physical therapists, and not all actually are aware of they have hip dysplasia, and maybe they treat something different. I know a lot of patients who have been treated for example, injuries to their hip flexors or gluteal tendinopathy, but without actually knowing that that joint also had some problems. And they can train and they can do a lot of different things, but if you don't know that you have to maybe take a bit care of your joint also, then it can be hard to prevent an injury in the longer run. So, and that would be my second one. So the first is to create more awareness about hip dysplasia, so a lot of different professionals and also maybe populations know about this and know that it is something that will affect a lot of younger females, but of course also some males, because we also have to remember that there's also the males who get this. So it's not only the females. And then the second one is that, of course, the timely diagnosis is one thing, but also maybe to trying to do some kind of preventive interventions, preventing that the individuals actually get an injury, because hip dysplasia doesn't result in any pain. It's only if you get an injury, either in your joint or in your muscle tendon structures. So I think the most important part is actually maybe also trying to prevent an injury. So if you have or experience hip instability, maybe there is a physio or GP who recognize this, then it's really important that you get some good advices for how can I support my hip, how can I take care of my hip, what it would be good activities, and what would be a bit bad idea for me to do, for example. So that will be the second one. I think it's really important also.
I think that's wonderful, and I think that you are spot on with all of that, and especially the awareness piece. I know in my physical therapy program, I graduated from physical therapy school in 2008. And I
Yeah,
remember we had a lecture on FAI, femoral acetabular impingement.
yeah,
A hip dysplasia never came up as something that you would see in an adolescent or adult. I'm a pediatric physical therapist, so I was very aware of it
yeah,
from a developmental hip dysplasia, looking at it for babies, looking at it in children with neuromuscular conditions like cerebral palsy and
yeah,
Down syndrome and things like that. But I actually, until I was diagnosed with hip dysplasia as a 31-year-old, I never even knew that it was something that you could see in adults. And that's because when I went to physical therapy school, that wasn't even in our curriculum. It wasn't in the textbooks. Um, I hope now that programs are at least starting to talk about it a little bit so that physios can think, oh, I have a young female with hip pain or a young male with hip pain.
yeah,
Maybe we should get an x-ray. Maybe we should
yeah,
just
exactly.
just rule that out before just assuming that we're treating hip flexor tendonitis or an adductor strain or a groin pull. So I
Mhm.
think that there is a definite need for sure. And I think also if we can spread awareness to people who are not in healthcare, patients,
Yeah,
helping them be aware of it so that they can ask their team, because not every medical professional is going to have it on their radar that
exactly. Yeah.
pain could be related to hip dysplasia. So many wonderful, wonderful things that you've brought up. And so I think to finish it off. So June,
Mhm.
we're meeting in late June. June is Hip Dysplasia Awareness Month. So excited that we got to have you on to talk about all of this month. But what is your team doing to celebrate Hip Dysplasia Awareness Month and to create healthy hips this month?
Yeah. At the time, I'm actually working on a paper together with a lot of very experienced researchers within hip dysplasia, and we're going to write a clinical commentary for JOSPT. The paper is going to be on hip dysplasia, where we're going to create a lot of awareness about hip dysplasia. So we're
Wow.
really trying to make a piece where we're trying to explain. So what is the clinical presentation? What's the normal symptoms? How can you make your tests? What would you see in the different tests? What kind of performance related deficits would you experience? What does the x-ray say? How can you interpret some of the images maybe, and things like that, and also trying to come with some recommendations for treatment.
Oh,
So
that
exercise
is
related.
very exciting. Thank you
Yeah,
for working on that. And for
yeah,
our listeners who might not be aware, so JOSPT is a very prominent physical therapy journal. It stands for the Journal of Orthopedic and Sports Physical Therapy. It's a journal that is widely read by physical therapists, especially those in the orthopedic and sports sections for different physical therapy programs. And so this is wonderful because this means that this information that you all are pulling together and writing is going to get into the hands of many, many, many people, physical therapists who are likely seeing patients with hip dysplasia in their office. So
yeah.
that is wonderful. Julie, when that comes out, definitely let us know. I know JOSPT, a lot of the articles are not open access, which means a lot of
Mm.
people you can't access them unless you're in a hospital or you
Yeah,
subscribe, through
yeah,
a physical therapy program. But when it comes out, definitely let us know. Miles for Hips, obviously we can't post anything that's protected under publication, but what we could do is help make the community aware so people can be letting their physical therapists know, hey, this information's out there. Make sure to access it and look into it because that is very exciting. So we thank your team and what a wonderful activity to do during the month of June.
yeah. I think it suits fine for hip awareness.
Yeah,
Yeah.
absolutely. It's so important. Well, Julie, thank you so much for joining us today. This really was so wonderful, and I think our community is going to love hearing about you and the work that you're doing. And we are just so grateful to have people like you doing this work, which is so important to patients and families. So thank you.
I'm very happy to take part of it. Thank you very much.